on COVID myocarditis. Let me first introduce Joe Gonzalez-Costello, who is Associate Professor of Medicine at the Differential Hospital, Barcelona University, and also happens to be the incoming president of the Spanish Heart Failure Society. Joe will give us his insights on our case, and will first share with us, if you can share your screen, Joe, please. We'll first share with us the situation in Barcelona for a few minutes. Not yet. And then we have Dr. Pullman here from pathology, Dr. Garcia, our chief from echocardiography, and then Dr. Zalta, and they will help us looking at the histology, echocardiograms, MRIs on a very interesting case. Joe, how are you doing with your screen?
Yeah, I'm sharing it, but I think someone has to let me in.
Okay.
There's a title here.
I gave him access.
So Rakna, can you stop sharing maybe? There you go. Try now, Joe.
Yeah.
There we go.
There we go. I don't know why it's not. Can't do
We
it.
can see it.
You can see it, yeah, but I can't put it on screen.
Do you have two screens?
No.
Looks like you're trying to click on your little
Yeah.
Icon.
There it is. That's
Yeah.
Try that again.
Now.
Okay.
Yes.
Now it's good. Okay, so I'd just like to give you a brief statement of what the situation in Spain is. We've been hard hit by COVID, as you all know, the same as you have. At end of May, we had 233,000 cases in the whole of Spain. And as you can see, most cases were around Madrid and around Barcelona, so the big centers where most of the population is. We had our peak of cases end of March, beginning of May, and then lockdown happened here on the 14th of March, which is when we started having the increase. And then slowly this has been decreasing, and fortunately now we have very few cases coming out, but we are getting away from the lockdown gradually. And as you can see, the total of hospitalized patients here on the right of your screen, and then more dead patients than ICU patients, because obviously some of the patients were not candidates for ICU, because then partially the ICUs were collapsed, especially around this time. If we see the situation in our hospital, so we're a big hospital in Spain, and at the peak, we had more than 500 COVID patients, around 90, and then gradually, as the number of hospitalized patients decreased, we had more patients in intensive care units and in intermediate care units. And regarding cardiology, we started to give support around the time of the lockdown. And then I imagine the same has happened in your hospital. Our coronary intermediate care started taking care of COVID patients. Then our cardiology ward was converted into an intermediate care COVID unit. Our ICU, coronary ICU, also turned COVID. And this lasted basically for a month and a half. Since the beginning of May, we're actually not in charge of any COVID patients except the heart transplant patients. So, and activity is gradually picking up. However, this has impacted, for example, interventionalists. So the number of PCIs during the end of March, which was around the peak of the COVID crisis, you can see that there is a dramatic decrease in PCIs and STEMIs and structural procedures. So there's also the mortality derived of the COVID pandemic of all the patients that are actually not seeking medical help because of the fear of getting infected with COVID. So this actually led in Spain to the Spanish Society of Cardiology to actually remind patients that if they have symptoms of myocardial infarction, go to the hospital and not wait because of fear of getting infected with COVID. It has also had a critical impact in our transplant activity. So here you can see the transplant activity in Spain. This is the whole of Spain, how it dramatically reduced from March and is still starting to pick up a little bit. The number of donors is still under the numbers we had prior to the COVID pandemic. And regarding heart transplant, here you can see it in red. We were doing around six to eight heart transplants per week in the whole of Spain, and this dramatically decreased, and we're now around less than 50% of the activity that we used to have before the COVID crisis. We've implanted quite a lot of ECMOs. So Spain is the second country in Euro ECMO with a number of implants. And our center implanted 17 cases. So we're the second in Spain of ECMOs. I have to thank Dr. Fuset for these images because she's in the intensive care unit and she's the one who has been in charge of all these mostly VV ECMOs. And here we can see the 17 cases, so 14 VVV and 3 cases of VA ECMO. And here we can see how we had 6 deaths, 1 during implant, 3 due to sepsis, and 2 due to pulmonary embolism. Actually, of the 3 cases of VA ECMO, 2 were PEs, and 1 of them was the myocarditis. We will comment later. And then the results, long-term results, are 65% survival. So 6 were discharged from the intensive care unit, 4 are actually being weaned from the ventilator, and 1 is in the process of weaning. And we do have 1 patient who is still with the VV ECMO in the process of weaning. So this would be my presentation. So now it would be Ragnar to start the case presentation.
Yeah, thank you, Zay. That's an incredible experience that you shared with us. We've been following Spain, obviously, as we've been trying to learn. We're always been a few weeks behind you, and I'm sure there'll be some questions at the end about your slides and the experience in Spain. We'll pass it on to Ragnar now. Go ahead, Ragnar.
All right, good afternoon, everyone. I'll be presenting a case of myocarditis and COVID-19 that we actually took care of about a month ago.
Ragnar, you're muted. We can't hear you. Okay, that's better. So start again, please.
Okay, so I'll be presenting a case of myocarditis that we took care of about a month ago. A 44-year-old gentleman, morbidly obese with a history of seizure disorder. He presented with a week of fevers, headache, cough, and shortness of breath. On admission, he was afebrile. His vitals were within normal limits. He had a white count of a mildly elevated white count of 12,000, a troponin of 3, CK of about 1,100, and proBNP was over 7,000. We checked a COVID-19 PCR swab and we found it to be negative. However, when we looked at his EKG, this is what we saw. So at initial glance, it looked like there were diffuse ST elevations, but on further discussion with the attending, we basically read this as an anterolateral STEMI. And as such, so Dr. Lateef, if you don't mind, if I was a fellow on call and I called you with all of this information, what would your first thoughts be and how would you like to proceed?
Yeah, I have to admit, maybe because I've been contaminated by the COVID epidemic, I'd be looking at this ECG a little bit more critically. And, my concern would be that the ST segment elevation involves more than one territory or more than one artery. There's also ST elevation inferiorly, okay? The other thing that I think I would point out is the PR segment in AVR. It looks elevated, okay? And so I'd be really thinking this is a myopericarditis. I'd want an echocardiogram. I'd want to see if there was a pericardial effusion, whether there was a regional wall motion abnormality, or whether there's global LV dysfunction. You know, as you know, throughout the COVID epidemic, we've continued to run a primary PCI service. So eventually this patient would get a cath in our service, because I think the diagnosis of myopericarditis is one of exclusion. But looking at the ECG, would suspect to find normal coronary arteries on the cardiac cath.
Wonderful. Okay, so that would be great in an ideal situation, but obviously this patient comes in when one of us fellows is on call, and our job is to describe this patient to the attending, and the attending decides to bring the patient to the cath lab for an emergent left heart cath. So once again, Dr. Lateef, if you don't mind, I'll run these images, and at the end, maybe if you could, or if you want to walk us through them.
Yeah, so maybe let it run again. So you can see there's a left Judkins catheter here, okay, left main. That's the LAD going all the way down. You see the circumflex vessel as well, and a large, what looks like ramus or early first diagonal. And I think the most important part is I'm not seeing any stenoses or any occlusive lesions or any thrombus on that view.
All right, so moving around.
And yeah, second view again, you know, looking more, showing us LAD a little bit better, really healthy vessels, looking at them, no evidence of STEMI or anterior STEMI, anterolateral STEMI, as you know, you may have suspected in the ECG.
Okay, so I think I have maybe one more view right here that opens up the LAD for us, right up to the
and
mustache.
Once again, yeah, normal left coronary system. You see this picture?
Right, and then just ending with a spider view of the same. And then we moved on to look at the right.
And also right dominant with really normal coronary artery as well. Yeah. So I think, you know, the ECG was a little bit confirmatory about that. It's not, although I'm not saying it's wrong to do the cardiac cath here. I think if in doubt, when there's ST elevation, and you know, my message is always rather do the cardiac cath than don't. Okay.
Sure. Okay.
Now you're back.
And gladly we ended with an LV gram.
So it's interesting, the LV gram, right? I mean, it's not really a dilated apex as you would expect with a Takotsubo, but there is hypokinesia involving most of the apical segments, the anteroapical as well as inferior apical segments. So it's a very localized apical hypokinesia that I'm seeing.
Right, and perfect. So this is how the cath was interpreted by the on-call attending. Normal coronary arteries, as we looked, with an EF of about 35%, and as you mentioned, lateral wall hypokinesis with hyperkinesis of the basal segments, thereby calling it sort of a Takotsubo variant at this point, and the LV-EDP was elevated at about 35. So just to pause and talk about Takotsubo a little bit, so we all know that it's typically supposed to be a reversible cardiomyopathy. The apical ballooning that Dr. Lateef was alluding to is seen in 80% of the cases. And the reason why we see such apical ballooning is because of the differential distribution of beta agonist receptors. There being more receptors in the ventricle, and therefore when there is a surge in catecholamines, these receptors are downregulated, and that results in the hypokinesis of the apex. However, it's important to be aware that even though 80% of the patients might have an apical ballooning kind of Takotsubo, there's other variants which you could see. So possibly our patient was having one of these variants of Takotsubo at the time this echo was performed, and hence the conclusion. All right. As far as Takotsubo in COVID-19 is concerned, because like Dr. Lateef mentioned, this is, you know, these were COVID times. COVID was the top differential on our minds. There are at least 3 case reports of Takotsubo in COVID-19. in all of these 3 patients with supportive treatment or treatment for COVID itself, EF did recover. Maybe one patient, if I recall, one of these 3 patients did require mechanical support, but the other 2 patients were able to recover their EF with supportive management. All right, so coming back to our patient, we did also perform a right heart cath, and this is what we found. The patient's MAP was 97. His heart rate was 110 at the time of this documentation, but averaging somewhere in the 90s. His right atrial pressure was 10. His PA pressures were 33, 18 with a mean of 26. His wedge pressure was 24. PG was 2. His SVR was 1400. PSAT was 64. And his peak cardiac output and index calculated were 4.7 and 2.2. So looking back at these numbers a little more carefully, we did realize that the wedge pressure was higher than the PA diastolic, which is not something you typically expect to see. And so we went and looked at the tracings one more time. So this was the RA pressure tracing. As you can see, the computer correctly picked a mean of 10 for the RA pressure. So we moved on to the RV pressure tracing. And again, RV pressure end diastolic was 10, which it should be similar to the RA pressure. And then we looked at the PA pressure tracing. So clearly not a very clean tracing, which happens more often than not. It's not always a textbook tracing. So there was significant respiratory variation that we saw. And as a result, we got 2 different sets of end expiratory readings of 20 and about 15. And so the computer correctly averaged it out to be 18. This was the wedge pressure tracing, which was even more chaotic than the pulmonary artery tracing. And if you notice, the heart rate went up between the PA pressure tracing and the wedge tracing. Again, you see that there are tall V waves, and the way you identify them is you basically coincide the pressure tracing with the QRS, and what comes right after the QRS is your V wave. So we're seeing tall V waves, which would either mean that there is some, the left atrium is stiff, or there's a component of MR. Once again, we see significant respiratory variation, and we typically like to measure the wedge pressure at the end of expiration. So this is about where we measured it. And it was in fact 24, 25. So after verifying the numbers with the tracings, we felt comfortable to say that maybe these numbers were just measured at different points in time. And hence there was such a discrepancy between the wedge pressure and the diastolic. All right, so moving along, take a careful look at these numbers, because I have an audience poll for all of you online with us. Hopefully this is interesting and fun, and I'd like to know what you think. So these being the numbers, should we reach for mechanical support before sending this patient out of the cath lab? You have 30 seconds to vote, please.
Joe, if this patient comes into your cath lab, you look at these hemodynamics, you did your due diligence on the tracings, of course. And what would you do here?
Well, I think at this point in time, the patient looks has good mean arterial pressure. He is certainly, there is an increased wedge pressure, which we haven't seen the echo, so I don't know whether there is significant MR or not, which may explain part of the V wave as discussed. I think, we should first start with diuretics, maybe try some vasodilators at some points. The vascular resistance are a little bit on the low side, so first start diuretics. And at the moment, I don't think I would start any mechanical circulatory support.
Okay, let's see what the audience wants to do.
Okay, so
yeah, I think we're in good shape here. 84% may continue to participate. So just diuretics, Rachna, what happened next?
All right, I just want to say we have 105 participants. We need a few more votes next time. All right, let's go. So moving along. So to summarize, just as Dr. Gonzalez said, this patient has elevated filling pressures. Left-sided pressures are higher than the right. Cardiac output is borderline at this point. His MAP is 97. His heart rate averages to be 90. So he's not in shock. And as such, as you mentioned, we did exactly the same. We diuresed the patient. We did not feel the need to use inotropes or mechanical support at this point. Wonderful. So we transferred him to the CCU. However, once he got there, he did become febrile. So we did check a second COVID RT-PCR, and it turned out to be negative again. But his SARS-CoV-2 IgG returned positive. So now the next obvious question on our minds was, is this an old infection that we're dealing with, or a recent infection, if I may say, or is this something new or ongoing? And how did we try to answer that question? We obtained some more data. We obtained an X-ray, which was read as pulmonary vascular congestion, possibly atypical pneumonia, and we obtained some of his COVID-19 illness markers. So, Dr. Yordi, if you were the attending in the CCU, you were rounding, and this is all the information you had, how would you put it together, and how would you like to proceed?
Yeah, very good. Millie, while we're at it, can you unmute Dr. Zalta, Benjamin Zalta, if you see him? So yeah, Vashna, very good. So we are concerned that this is COVID, but the swab is negative, which we have now seen this several times, negative swabs, but he already has an IgG antibody. So we're uncertain whether this is an active process or not. The blood work here, the LDH of 900, the D-dimers that are elevated, and the high ferritin strongly suggest that this might be COVID. The procalcitonin level is low, and therefore we do not think this is a bacterial infection. Is Dr. Zalta live now? Okay, so I'm going to be the radiologist and agree with this assessment that this is pulmonary vascular.
There we go.
Yeah, we can hear you. Go ahead. You want to comment on this X-ray?
Yes, what we can see on this X-ray, there's a right IGS-1 dense catheter with distal tip in the distal right main pulmonary artery. There is the cardiac silhouette is enlarged, and there is increased airspace specialties in mid and lower lungs without pleural effusions. Given the pandemic of COVID, this is what we are worried about, and this is what we would report, something like this, as possible infection.
Okay, very good.
Especially
Ben,
when we
you
don't
have
see...
you have a big echo. You need to turn off one of your devices, and let's give it back to Raj now, but don't go away. Just turn off one of your devices. And so we have this X-ray. We are not 100% sure what's going on. We suspect COVID pneumonia. Rachna, do you want to go further from here?
Sure. So, all right. Thank you, Dr. Zalta, for that reading. And I will ask you a quick question in about a second. So, or a few seconds. So at this point, Dr. Yordi, would you want more imaging? You have a procalcitonin of 1. You think this may be active infection. Would you proceed with a CAT scan? And if you don't know, I have a backup option for you. Or if you're not sure. All right.
Okay, very good. So let's poll the audience on this one too, I think, whether we should do a CAT scan here. Do we need further information? And is this going to be consequential at all? I have to say that as a clinician at the bedside, I have everything I need. Depending on the situation with the white count and fever, I may start empirical antibiotics. Mm-hmm. But at this moment, I don't think I would pursue a CAT scan. That can be controversially discussed, and I believe, Rachna, you have some more information. Do we have an audience response for this?
Yes, it's in progress right now, and I've definitely managed to convince a few people to vote, so I'm very happy about that. Dr. Zalta, yes. If you can still hear me, do you think we should go ahead with a CAT scan? Would that be indicated, and how would it help?
Let's just show the response from the audience, which I think is interesting. Just before we let Dr. Zalta respond. So, majority of the audience thinks that a CT probably is not going to add very much. So about 60% think a CT is not going to add very much. Go ahead, Dr. Zalta.
Dr. Zalta?
Yes, audio struggle. Go on, Rachna.
Okay, all right, okay. So yeah, so we have sort of some confusion here. Should we go on with the CAT scan or not? And really, if we turn towards the guidelines, again, we don't have such a great answer about this question. these guidelines are all from March, when the pandemic was maybe first being diagnosed in the US, because as we all know, we did not have enough testing at the time. But also in China, where they had already had a few months of COVID-19, they thought that a CAT scan was recommended for diagnosing COVID-19 in its early stages. But on the other side of the globe, in the US, the CDC and the American College of Radiology actually recommended against using CAT scan, mainly for two reasons: that the CAT scan findings are most likely non-specific, given that there are many other viral illnesses going around at the same time, and also because of the infection control issues. So exactly for those reasons, we decided not to proceed with the CAT scan. We didn't think it would add anything to our management. And we sent out, blood cultures and urine cultures to investigate these fevers. Coming back to cardiology.
Rachna, before you go to the echo, I just want to see in Spain, the CAT scan situation. Do you agree, Joe, or would you get a CAT scan?
I agree. We're not doing CAT scans on a regular basis for the reasons you said. I mean, infection control issues are serious enough. I mean, getting these patients to the CAT scan, it's complicated, and then most of the times it's not really going to help you that much regarding treatment. So, so I totally agree with the US in this one.
The one argument one could make, and I wouldn't make it just to be complete for didactic, is that it might help you in making we're supposed to prone these patients, and sometimes this could help. But Rachna, do you want to go on now?
Yeah, I would love to go on to echo, something that we do more commonly. So I'll show you some of the echo images. I wonder if Dr. Garcia has been able to join us. If not, then
he's there. I see him.
Okay. Can we please
unmute Dr. Garcia?
So this is
he's unmuted.
Wonderful. So personal long axis view, into which we zoom in, trying to see the right ventricle a little better in the view. And moving on to a 4-chamber view. Again, clearly this test was technically difficult for this particular patient in the given situation. And this is the pulse wave across his LVOT. And finally his IVC, which measures out to be about 2 centimeters with less than a 50% compression. So Dr. Garcia, if you could summarize this echo for us, please.
Yeah, I don't think he's on the audio. I spoke to him about this actually at the time, and what he pointed out is that they have wall motion abnormalities that are not in a coronary distribution, and that the myocardium was quite thick, i.e. edematous, and that this might be consistent also with the myocarditis. And if this had been one of our other patients post-transplant, he would have possibly suggested that there's rejection. He also pointed out the bowing, what we can see here, of the intra-atrial septum to the right, suggesting a high left-sided filling pressures. So echo with, I would say, moderate, severely reduced ejection fraction, some regional wall abnormalities, not in a coronary distribution. So we can move on.
And as we, all right, so as you mentioned, elevated biventricular pressures. So at this time, we have all of this information, and obviously we're thinking of our differential diagnosis. As we discussed, Takotsubo was probably one of the top runners because it has been seen in COVID, and we thought we saw something similar on the LV-gram. Minoka was probably also on our mind at the time. Now, by this time, we had some of his other laboratory work back. So his hemoglobin A1C was 6.5. He had not been previously diagnosed with diabetes, was not receiving treatment as such. And Minoka could possibly have caused the wall motion abnormalities that we observed. And last but not the least, myocarditis, which may have either been an acute myocarditis in the setting of an ongoing COVID-19 infection, or subacute in the setting of an inflammatory response to a recent COVID-19 infection. Or it could simply be a myocarditis of a completely different origin, although we really didn't think that he would show up with giant cell or necrotizing eosinophilic myocarditis in the middle of COVID-19 pandemic. So moving along. We brought him to the CCU, as I mentioned. He was having these daily intermittent fevers, and his white count actually kept trending upwards, but none of his cultures returned positive. His blood pressures were on the lower side, 90s over 60s at best. We repeated a TTE at a transthoracic echo at 1 week, and we found absolutely no changes. Our clinical diagnosis at this point was myocarditis. Given all the evidence that we had, it was probably our top runner. But we'd like to ask you if you agree with us and what you would do next. So I'm going to bring out the next audience poll. Myocarditis. What would you do
while
next?
we're waiting for this, let's hear from Dr. Gonzalez-Costello. What's your take here? Is this Takotsubo? Have you seen Takotsubo in COVID patients? Is this a myocarditis? And you can maybe even I think you see the poll here. What should we do? Would you just observe this? Would you start to treat this patient with steroids and IVIG? Do you need more testing? Should we do a cardiac MRI or do a biopsy?
Yeah, I think Takotsubo as an original diagnosis looked probably the best option originally, but it should have evolved to improvements. Normally Takotsubo in 1 week really gets better. On the other side, the echo, what's surprising is the thickening of the myocardium. So that goes in favor of myocarditis, and the fact that it hasn't improved over the days goes more in favor of myocarditis. Minoca could be an option, but given the context of the inflammatory disease we see in COVID, I mean, myocarditis with no virus at this point in time could be a feasible diagnosis. And I would go for MRI and endomyocardial biopsy, both before starting any steroids and IVIG.
Okay.
So I think it's worth showing the poll, Uli, and I'll just mention that Mario said that the pattern on echo was compatible with myocarditis. He would predict increased edema and abnormal T1 on MRI. But I think the results are interesting because it's pretty split between the different options, right? From our colleagues. About a third would get an MRI, about a third would start steroids and possibly intravenous immunoglobulin. So we'd like to see.
Let me underscore that this result underscores why we're here today.
Absolutely. And the reason I'm smiling is because this is exactly the discussion we had amongst ourselves. 1 week out, patient has not improved from the standpoint of his EF. He's still having daily intermittent fevers. How do we proceed? So we went back and discussed some of the guidelines and evidence, to support the use of cardiac MR or endomyocardial biopsy. As far as a cardiac MRI is concerned, if we see the presence of edema or late gadolinium enhancement, like as Dr. Gonzalez mentioned, it could very well be diagnostic of myocarditis, and then we'll feel a little more comfortable treating it as such. If you look at the guidelines, 2016 European Society of Cardiology for acute and chronic heart failure, they do recommend cardiac MR in patients who are clinically stable and in whom you clinically suspect myocarditis. It's actually a class 1 recommendation. They actually go on to say that you may be able to identify specific viruses because of the different patterns of late gadolinium enhancement that that would result from a different viral infection. And on similar lines, the 2016 AHA scientific statement also says that if you clinically suspect myocarditis in a stable patient, you must go ahead with a cardiac MRI. As far as an endomyocardial biopsy is concerned, there's a 2007 statement that puts together 14 scenarios where an endomyocardial biopsy is indicated. And one of the very first scenarios that they talk about is that of new onset heart failure that's less than 2 weeks of duration, is associated with a normal or dilated left ventricle and hemodynamic compromise. So that was the only thing that our patient was missing, was that he was hemodynamically stable for all intents and purposes. And so we didn't feel as compelled to bring him to the cath lab for a biopsy at this time. We went on to observe the patient. However, on day 9, he developed frequent ventricular ectopy and a VF arrest. Now, of course, again, this happened overnight on call, and one of our fellows did a stellar job of resuscitating this patient in about 2.5 minutes. He was started on IV amiodarone and then developed monomorphic BP, for which he received 2 shocks and was back in normal sinus rhythm. But at this point, he did meet a class 1 indication for an endomyocardial biopsy. So we brought him to the cath lab the very next morning. This happened sort of overnight, post midnight. So we bring him to the cath lab, and these are the new hemodynamics that we see. And as I'm reading them for you, Dr. Yordi, my question to you is, how would you proceed? So the patient has a MAP of 91, his heart rate is 89, his right atrial pressure is 22, his PA pressure mean is 33, his wedge pressure is 25, his SVR is 1500, almost 1600, a PA sat of 31%, and an output of index, therefore, of 3.5 and 1.5. So definitely change from the first time we looked at these numbers. How would you proceed?
Yeah, so the patient has clearly progressed. And to sum it up, there's now severe biventricular failure. If you recall early on, the right atrial pressure was, I believe, around 10, and the wedge was 25, with really just left-sided heart failure and a preserved cardiac index of 2.2. This has completely changed now. Now the cardiac index is extremely low at 1.5, and both right atrial pressure and wedge are very high and almost the same, indicating probably severe right-sided component.
Great.
So now
I'm sorry, I'm gonna interrupt you there, because I think I want everyone now to tell us, now that you've interpreted this for us and given us the clear picture of what this patient's looking like, what would we do next? So I have one last poll for everyone. What would you do next? Would you go for pharmacotherapy, an intra-aortic balloon pump, an Impella, an ECMO, or go straight to a Centromag BiVAD?
Yeah, this is going to be, I think, a very interesting discussion. Let me just confirm that either Dr. Forrest or Dr. Goldstein are on the call and can be unmuted. They may be in the OR doing real work. But if they are, please unmute yourself and step in. This is a discussion that we had, but let me first ask our guest, Joe, what's your take on this? Anything else you want to know? Are you ready to unleash mechanical support? We're much closer now, for sure.
Yeah, I mean, certainly he needs some help right now. He has biventricular failure. The question is whether you can get him out of this without ECMO, which would be the option you could use, certainly because he's had arrhythmias, and this, if he has recurrent arrhythmias, he's going to be in trouble. I would like to know, is he on any inotropes at this point in time?
So he just had an episode of VF arrest. And
no inotropes.
Yeah,
no inotropes. The other thing is, maybe get him on some inotropes. I mean, the cardiac index is low. So a first option could be intra-aortic balloon pump, a little bit of dobutamine with the amiodarone, see the results of the endocardial biopsy and treat this, and then have ECMO as a standby. That would be maybe the first option.
Okay, Joe, let me just also pull Azim in now. It is my understanding that the intra-aortic balloon pump doesn't really do much in shock. Is that not correct?
Well, certainly, in the studies looking at intra-aortic balloon pump for cardiogenic shock in the setting of STEMI, they've all been negative, right? I mean, and certainly in the United States, I've heard some very senior people in interventional cardiology say there's no role to have a balloon pump in the cath lab anymore. All you need is an Impella or ECMO. Personally, my honest feeling, having come from Europe, where having worked in Italy 12 years, where Impella is still extremely expensive and not as easily available as the United States, we've used balloon pump on a regular basis and had very good results with it. And certainly in a patient like this, I would start with a balloon pump and then see how he does, pharmacotherapy and a balloon pump, and then escalate if need be. It wouldn't be my first choice just yet to put this patient on Impella.
Okay, very good. Let's stay on this for a moment. So you said something very important that I just want to underscore, and now we see our audience here. Again, we're picking the right teaching topics because it's not so clear. The balloon pump literature is indeed only in STEMI, and this is not a STEMI. So we have really no evidence here. In heart failure, I would say anecdotally, and Joe can comment on this, clearly the balloon pump works frequently, and our own philosophy is to try balloon pump. Now, it's also important to understand that we're dealing with COVID here, and we're dealing with a hypercoagulable state. And I know, Joe, because of the cost, the impeller is not as often used, but this would be a concern for us. Placing a impeller device and ECMO into a patient who is potentially hypercoagulable, because the complications from these devices are bleeding as well as clotting. So with a D-dimer of 6, a possible hypercoagulable state, we'll do it if we have to, but that's just another dimension that we take into consideration here. Joe, do you want to add anything on that, or should we place the balloon pump now?
Yeah, I agree on what you said. I mean, we have to take into consideration the coagulation problems associated with COVID. And, you know, ECMO is easy to put in, but then the consequences can be dear. So I would start with the intra-aortic balloon pump, pharmacotherapy. I know the literature is not there, but in real life, as Ian says, you know, we see it works in these patients. So it gives you that little bit more. And we have to remember the patient is naive regarding inotrope treatments. I know he just had VT, but still, I mean, you might sometimes, if you increase the cardiac output, then you also reduce the incidence of ventricular arrhythmias. So that can help in a way, but always have the ECMO ready just in case. And regarding the impeller, I agree, and you can also have coagulation issues with the impeller too. So that is something to take into consideration.
Wonderful, great discussion there, and I'm glad to reveal that we chose an intra-aortic balloon pump and 8 French through the right femoral artery, with providing 1-to-1 support and an augmented mean of about 80. With this, the patient was brought back to the CCU. I apologize. With this, we proceeded with an endomyocardial biopsy. And at this point, I'm very excited to invite Dr. Pullman, who has been kind to provide us with the pathology slides.
Just go to the next slide, Rachna, and I think Dr. Pullman is live, and he can just direct you to advance the slides. Yeah, Jim, can you hear us?
Can you hear me?
Yep, good. We can hear you loud. Yeah.
So we got this biopsy, and it's 6 pieces of myocardium, one of which I divided in 2 under the dissecting microscope, sent half for electron microscopy and half for viral determination by RT-PCR. So you're looking at a representative fragment here, which shows fairly diffuse interstitial mononuclear infiltration or inflammation. There is a bit of myocyte injury, which I will show you later on in more detail. Next. So this shows that the substantial proportion of the inflammatory cells were CD3 positive T cells. Next. And even more were CD68 positive macrophages. And there were a smattering of CD20 B cells and a few plasma cells, but mostly macrophages and T cells. Next.
Jim, I learned this from you. I'm just going to go back one slide, please, Rachna. I'm going to make this a little more pedestrian where I was before you taught me. So all the brown spots here are macrophages. Is that correct?
Yes, the brown. The brown is the immunostain, which is lighting up the particular inflammatory cells, which you can certainly see on the H&E slide that I first showed, but you need this to subtype them.
Okay, great. Thanks.
So this one of the 6 fragments looked a little different. This is in fact myocardium, which I proved on a trichrome stain. This is rather severely damaged and differs from the other, not only its degree of damage, but it has a different kind of inflammatory infiltrate, which you'll see in the next slide. A lot of eosinophils clustering in the area of severe damage. And the eosinophils are all these cells with the pink cytoplasm. And I don't know if it shows up here, they have little red granules. So
yeah, we can see that. Maybe Rachna, can you move the cursor around a little bit? Move it to like, say 9 o'clock in the screen, or Jim, you tell her where to go, but is that where the necrosis is seen best?
Yeah, actually the prettiest eosinophils is at 6 o'clock on the bottom of the screen.
Right.
Yeah, yeah.
The characteristic twin nuclei and the very bright red cytoplasm. Unfortunately, you're not really seeing the granules all that well. Although right around 12 o'clock there is a beautiful eosinophil there with its granules more visible.
Okay.
But this is we see these eosinophils in reaction most prominently in the myocyte necrosis and injury that occurs in T-cell mediated transplant rejection. And here, this is clearly a totally different scenario, but we're getting a similar kind of infiltrate, which can be seen in other kinds of myocarditis as well.
And before we go to the electron microscopy, just direct Rachna to show us myocyte necrosis in any of the slides where you feel it's best shown.
Looking here, so in this slide here, if you go around 3 o'clock, where the yeah, there's some bright red cytoplasm there, and these cells have pretty much lost most of their nuclei, and the cytoplasm turns bright red, which is characteristic of denatured myofibrillary proteins, and is indicative of myocyte necrosis. Actually, as it turns out, and you can also see around 10 o'clock towards the upper left,
yeah,
there's some myocytes there that are they're very thin. If you go a little bit to the left, yeah, there's one there. Just move it up and down. There's like a sinuous sort of leftover, almost totally dead myocyte whose cytoplasm is much thinner than your typical healthy myocyte. I found in this case, if you want to go, the EM actually shows the myocyte damage much better.
So why would you do electron microscopy here? Is this part of your routine, or does that have to do with this specific myocarditis?
So we actually do electron microscopy with some frequency to identify the etiology in myocarditis. In this case, it was done for that purpose. Actually, we were hoping to visualize the SARS-CoV-2 virions. We did not find them, nor did we find them by the more sensitive assay of RT-PCR. As it turned out in retrospect, is congruent with what other people find, and not too surprising if you think about the overall process. However, the electron microscopy here was extremely useful in illustrating myocyte injury. So click once again. And you see the V's mark all these intracytoplasmic vacuoles, which are characteristic of the cytoplasmic or the sarcoplasmic degeneration that one sees in a variety of injuries. Click again. There is also myofibrillary loss in a process called myocytolysis, when the cytoplasm breaks down and forms these little granules. And click one more time. And you see here contraction bands forming where the spacing between the adjacent Z lines is much smaller than it should be. And click once again. And on this side, you see there is stretching of the myofilaments, myofibrils, so that they are much greater than normal. So both the stretching of myofibrils and the condensation are characteristic of myofibrillary injury, and sometimes called the contraction band necrosis, particularly on the right. So the next slide, the last one I'll show, this shows, in addition, there's much more myocytolysis here. As you see, there are many fewer myocytes. So click once. So this is called colliquative myocytolysis, one of the several types of cell death myocyte that's associated with ischemic type injury, which is not restricted to ischemia, however. And click one more time. And there we see some mitochondria that are showing some degree of calcification, which is typical, again, of cell injury in general, with breakdown of the mitochondrial membranes and formation of calcium salts from ATP, from anyway, basically you get calcium phosphate depositing in some, but not all the mitochondria. The ones toward the bottom, mitochondria at the bottom of the screen or elsewhere are still healthy. So the last slide, here's a summary. I'm calling this myocarditis, moderate to severe. There's a lot of, fair amount of scattered myocyte injury and necrosis and an extensive interstitial inflammation, predominantly T-cell macrophages, but with a significant population of eosinophils. We did not identify coronavirus by either electron microscopy or RT-PCR. And I'm making this up now, but I'll call this COVID-19 cardiomyopathy, and I'll define it basically on what I'm seeing here. Notably, we also did not see any evidence in this biopsy of any thrombotic microangiopathy, which could be sampling, but certainly we had enough capillaries where we probably would have been able to see this if it had been there.
Okay, that was terrific. And I have to say, you have spent too much time with our team. We love to make stuff up, and then in the end, it may come true, right? So, yeah. Rashma, do you want to move on here? We have about 15 minutes to go.
Thanks very much, Dr. Pullman. So this was myocarditis, and we went one step further and called it pulmonary myocarditis because now our patient had evidence of cardiogenic shock, had developed a fatal ventricular arrhythmia and sudden cardiac death. And he was SARS-CoV-2 IgG positive at this time. So what do we know about myocarditis in COVID-19 and how should we proceed? So as far as myocarditis in COVID-19, there are at least 3 case reports that I came across. These patients were all SARS-CoV-2 RT-PCR positive. 2 of the 3 patients had received immunomodulatory agents such as IVIG or steroids. 1 patient developed cardiogenic shock and additionally required mechanical circulatory support. All 3 patients did recover their EF, but the 2 patients who received steroids eventually developed superimposed bacterial infection and died. Here are the references for those case reports. And then moving on to the evidence or the guidelines that, how they direct us in terms of using immunomodulatory agents for myocarditis. It's actually interesting to note that the guidelines for adults, which were recently published right before the pandemic was identified or struck New York, if I may say, in February, where the adult guidelines cautioned against the use of steroids and IVIG in cases of pulmonary myocarditis, whereas the pediatric guidelines have always been in favor of using immunomodulatory agents for myocarditis. We saw a similar pattern in terms of COVID-19 myocarditis, where we had only 1 case report of COVID-19 myocarditis, which was treated with IVIG and steroids. But we have a case series of 35 children who actually got better with the use of IVIG in every single one of them, with about 1/3 of them having received steroids in addition, and 1/3 of them having been on ECMO. All of them were no patients died. They were all discharged, and the ECMO was weaned off successfully in the 1/3 of patients. So just very contrasting guidelines in terms of use of immunomodulatory agents in COVID-19 myocarditis. Coming back to our patient, he was SARS-CoV-2 IgG positive. All of his cultures were negative. No virus was detected on the endomyocardial biopsy, as Dr. Pullman mentioned. And so we felt comfortable treating him with IVIG and high-dose steroids. And this was started the day after the biopsy because we had the results fairly quickly. Over the next 3 days, he actually improved hemodynamically. He was quiescent from a ventricular arrhythmia standpoint, and we were able to successfully wean him off the intra-aortic balloon pump. We repeated a TTE at this point, and we found that the EF had remained same, but we were seeing thinning of the apex and the inferolateral anterolateral walls. The apex was also akinetic at this point, and the other walls were hypokinetic. So we went ahead and obtained a cardiac MRI to understand if in fact the patient had in some way responded to the treatment for myocarditis, and to be able to treat him further. So Dr. Zalta, if you're on the line, I have your cardiac MRI images here.
Do you have the cardiac MRI? Yeah. So this patient who came to us with shortness of breath, and he was not able to lay down on the magnet table. Also, he had some difficulty holding his breath. We decided to start with the most important sequences, which were to do the contrast and delayed enhancement first, since our most important in this case, and the functional imaging we could do later. And that's what you see here. We ran first a edema sequence T2 spur, and these top two images show 4-chamber view, and you can see the diffuse edema involving the left ventricular and the right ventricular wall. It's not only one chamber. Same thing is seen on short axis near the apex, mid, and near the base. Exactly. Now, the next slice. These are the delayed enhancement images. Most of the sequences we obtained during this MRI were free breathing because he couldn't hold his breath long enough for us to obtain meaningful and better quality images. So you have to forgive us. And these images you appreciate.
If you can just be, for most, not everybody knows how to look at MRI. If you just be little more, just explain what the different colors are, the white, the gray, and where we are here for those fellows that may be just very early in the career. That would be great.
These are short axis images near the apex, mid, and near the base. You cannot see my mouse, right? Obviously.
No, but you can direct Rajnath where to put the mouse.
Okay. Top left image near the apex. You see there is delayed enhancement, white signal in the lateral, apical, and anterior septal. I mean, apical septal, I meant to say. And there's thinning, which we'll see better on the 4-chamber in a second. Next image, top middle. Yeah, you see more of delayed enhancement. The pattern here is a mid myocardial. In the next image on top, sub-epi in location. And you see more of the same findings, sub-epicardial delayed enhancement with preservation of the subendocardium. On the 4-chamber, one single view I show, you appreciate the thinning of the apex and delayed enhancement.
Yeah, and I believe you mentioned transmural edema was seen, right?
Correct.
Fine. Okay.
This is a non-ischemic or non-coronary pattern of delayed enhancement. Next slide. This slide shows the, if we play it, the cine showing short axis from apex to base. As you can see, it's jumping a lot because free breathing acquisition. One more time. The anterior lateral wall, very hypokinetic, or near the base, you have better contraction compared to mid and apical segments of the heart. You appreciate that. And of course, there is global hypokinesis as well. But these are areas that I mentioned are worse. Apical segments, anterior mid, and anterolateral walls. If you go to the next segment, next slice, I'm sorry. Here is one single slice, semi-4-chamber it's called, and you here appreciate the movement, lack of movement of the apical segments. These segments cannot be assessed on short axis because they are in the plane of acquisition. We can see them better on these sequences. The final diagnosis was most likely myocarditis related to COVID.
Okay.
This is a two-chamber view showing the same thing here.
Terrific. Thank you very much. Rachna, can you go to the next slide? That was great. Thanks so much.
Sure. So at this time, we have the MRI. We're seeing features suggestive of myocarditis, and I believe we can rule out what we initially considered Minoka as one of the differentials, given his potential risk factors. So we went ahead and completed a prolonged prednisone taper, and we also started him on goal-directed medical therapy for heart failure, because now he had heart failure secondary to myocarditis, sure, but it definitely did merit goal-directed medical therapy. So that was initiated. An ICD was placed for secondary prevention, given the episode of VF early on in the admission. And after 22 days of admission, we were finally able to discharge the patient home after having completed his prednisone taper while he was with us inpatient.
Okay, Rachna, very good. So we have maybe 5 minutes or so, and I think we should hone in on the main teaching points of this session. And I'm going to call on Sasha Vukelic, who has really been very active looking at these myocarditis cases, if he can hear us. Sasha, if you can comment briefly on what have you seen? Have you seen different presentations specifically regarding MRI, resolution, persistence? Why do you think that is? And what do you think the treatment should be, and when should it be started? In less than 3 minutes.
We've seen up to eight to nine patients here, and we have the two patterns of development of disease. So one, everybody presents with cardiogenic shock, as you can see in this case. In some other cases, some patients need inotropes initially, but we have two different patterns. Approximately half of the patient we saw recover in 5 days with no MRI changes. With no MRI changes, there is no edema, there is no damage. So there is a transient decrease in function over 5 days. And interestingly, those two cases did not have Takotsubo appearance. These 5 cases did not Takotsubo appearance. This other group of patients, which this show prolonged or progression of disease, progression of the injury, and it's confirmed on biopsy also. So the problem is, in this moment, we do not know who is going to progress and who is going to recover fast. And if we wait with the therapy, sometimes you can see it can be dangerous for patients because this gentleman developed VFib arrest. So in this moment, because we definitely see that this is immunological injury without viral presence, that in my opinion, we should treat patients very early with anti-immunomodulatory therapy with IVIG and steroids to prevent the progression of the disease.
That's great. Just in case somebody's wondering why the patient hasn't been like many of our patients in experimental therapies, you generally have to have a positive viral swab in these protocols. So Joe, if you can close us out, what's your take on this? How do you approach these patients? At what point do you give steroids, neglecting the lung situation and indications there?
Yeah, I totally agree with what Sasha said, and I think I congratulate you on a great case. And I do agree that treating early these patients with IVIG steroids, I think it makes sense in order to avoid worse outcomes. For example, this patient, he probably had some disease initially, which may have gone unnoticed, and then eventually developed because the biopsy findings are with so much macrophage infiltrate indicate that the disease was going on for some time. Actually, the case I have shows the evolution of this myocarditis at different time points. So I totally agree that treating early with steroids and IVIG, although you do increase the risk of bacterial or fungal infections, I think that you have to take in the balance with the risk and the benefits. So I think you can finally benefit from this.
Okay, terrific. So I want to use the last 30 seconds to thank our consultants, Dr. Pullman from pathology, Dr. Zalta from radiology. Dr. Garcia is not really a consultant, he's our chief. And then, of course, Professor Gonzalez-Costello from Barcelona. Thanks for joining us. And we'll have to bring you back with your ECMO COVID case. We're running out of time here. And Rachna, that was terrific case presentation. Thanks, everybody, and goodbye.
Thank you.
Thank you. Goodbye. Well done, Rachna.
Thank you.
Thanks. Goodbye.